Hello and welcome to the Family Heart Foundation webinar, Getting Your LDL Cholesterol to Goal and Staying There. I'm your host, Kat Davis Ahmed from the Family Heart Foundation, and we are very lucky to have with us Dr. Mary McGowan, the Chief Medical Officer of the Family Heart Foundation, this evening to present on this really important topic. We're so glad that you're all here. We did have planned our guest speaker, Brandon Wilson. Unfortunately, he's not able to join us this evening because of his familial hypercholesterolemia and heart disease, he had to go to the hospital this evening. So just a reminder of how serious this topic is and how important it is to find and treat high LDL early in life. So again, we're so happy that you're here. Thanks for joining us. We'll do a little housekeeping. First of all, just to make sure we say this webinar is for your information. Any specific questions you have about your own care, please talk to your own healthcare provider, your doctor, your nurse practitioner about those questions. And if you need help finding a specialist who can answer those questions for you about your cardiovascular disease or inherited lipid disorders, we are here to help. And at the end of this webinar, we'll give you the link to the Care Navigation Center at the Family Heart Foundation. Please introduce yourself in the chat. It's wonderful to see people here from all over, and it's nice for you all to meet each other there in the chat. And if you have questions, please feel free to enter them throughout the webinar in the Q&A section, which you can find also at the bottom of your screen. And we will answer those at the end after Dr. McGowan's presentation. The Family Heart Foundation would really like to thank Amgen for its support for this program called the GOAL program, where we're working to understand why more people are not reaching their LDL goals and what gets in the way of preventing cardiovascular disease by achieving guideline recommended LDL-C goals. So without further ado, I'd like to introduce Dr. Mary McGowan, Chief Medical Officer of the Family Heart Foundation. Thank you, Mary.
Thanks, Kat. And I'm hopefully going to be able to share my screen. Let's see, here we are. So Kat, thanks very much for having me speak this evening. And I'm going to be speaking about getting to your LDL goal and staying there. Why is it so important? And usually we talk about familial hypercholesterolemia and lipoprotein(a) on all of our webinars, but this is going to be somewhat more broad, and we're going to talk about goals and safe spaces for LDL, the safe zone for LDL for people with atherosclerotic vascular disease, and we're also going to talk about it for people who have not had a cardiovascular event at this point, and we hope you never will if you get to your LDL goal. So I'm going to talk a little bit about elevated LDL as a direct cause of atherosclerosis, and I think that it may be the case that many of you think, well, atherosclerosis is caused by inflammation. The bottom line is, and we'll talk a little bit more about it, it's elevated LDL that is the requisite. And then that elevated LDL can ultimately lead to an increase in inflammatory properties inside the artery wall. We'll ask the question, what is the optimal LDL? We'll look at LDL goals. And, you know, when we say LDL goals, you'll see this is a bit of a moving target, and it's not because we're changing our mind, it's because science is giving us more and more information. So we'll talk about that for adults and children with and without atherosclerotic cardiovascular disease, so plaque in the arteries. We'll talk about why does getting to goal or to a safe LDL matter. And I think really importantly, something that's not brought up frequently is why is staying at goal or in a safe LDL space matter even more. And we now have lots of data that shows that really it's the length of time with a low LDL that's the most important. So we'll talk about management of elevated LDL. We'll talk about lipid-lowering therapies and things that are on the horizon for lowering LDL. So our arteries are healthy when we're born, whether we're born with underlying genetic disorders that lead to elevated cholesterol. We're all born with healthy arteries. And so what is a healthy artery, or what is a normal artery? The normal artery has 3 layers. The outermost layer is called the adventitia. The middle layer is called the media, and the media is what gives the artery strength. And then the innermost layer is where the action is in terms of atherosclerosis. The intima is where you start seeing plaque develop. And then lining the intima, it's the space between the intima and the blood inside a blood vessel, are these specialized cells called endothelial cells. So the normal artery is really beautifully designed to transport blood, nutrients, and oxygen from the heart to all areas of the body. And the endothelial cells that line the artery wall, separate the intima from the blood, they're special cells, those endothelial cells. They can produce chemicals which can allow the artery to dilate or expand when even more blood flow is needed. So if you think about when you're exercising, those leg muscles or arteries in the, your leg muscles need more oxygen, more nutrients. And those blood vessels dilate. When you're digesting food after you've had dinner, for example, you need more blood flow to your stomach, and those blood vessels dilate. The endothelial cells also prevent unwanted clots from forming in arteries. And we can think about these clots, they can increase the risk of a heart attack. So important that the endothelial cells can produce chemicals that protect us. Elevated LDL increases the risk for atherosclerosis or plaque buildup within the arteries, whether those arteries are the arteries to our neck, serving our brain, our heart, or even our lower extremities, our legs, where if you have a blockage in your leg arteries, you may have what is called critical limb ischemia, not getting enough blood flow to your lower limb. And so let's find out how LDL is involved. So this is a depiction of an artery through the years. So atherosclerosis develops over time, and treating high cholesterol, particularly high LDL, early in life can prevent the development of atherosclerosis from occurring in the first place. So that's called primary prevention, meaning before anyone's had a heart attack or a stroke, you're treating the cholesterol to prevent that. But if you've already had atherosclerosis, if you've already had a heart attack or a stroke, it isn't too late. The goal in secondary prevention is to treat all risk factors aggressively, particularly the LDL cholesterol, to prevent another event. And you need to advocate for yourself for proven therapies. Just as a digression, since we don't have the opportunity to speak with Brandon tonight, Brandon and Kat and I were on a call earlier this week preparing for this program. And Brandon was describing his interaction with Kat and how it actually saved his life. And, I think I can speak for Brandon in saying that he was not getting adequate care. He is a young man. He's in his 30s. He has lots of little children at home. He had bypass surgery, had, cardiovascular disease. And granted, he started out with an astronomically elevated LDL. And on statins and ezetimibe, his LDL had gotten down to 140. It was more than half of what it was, been dropped by more than 50%. But his LDL was 140. The goal, or the ideal for somebody with cardiovascular disease, is now set, as we'll see, an LDL less than 55. And Brandon had an LDL of 140. He found the Family Heart Foundation and had numerous conversations with Kat. And Kat said, Brandon, this is not sufficient. You need a lower LDL. You need at least less than 70, ideally less than 55, and lower is better. And he got the tools from the Family Heart Foundation to express to his physician that he didn't think that this was, it wasn't good enough for him. His LDL of 140 was more than twice what he wanted it to be. And he was sort of given, back of the hand. And that's when Kat empowered him to say, I think I need a new physician. Brandon told us the other day that on the combination of a statin, ezetimibe, and a PCSK9 inhibitor, his LDL is now 30. And he feels as though he might, have a long life. So that's what we're here to do, is help you advocate for proven therapies, advocate for what's good for you, what you need. So looking at this artery, this is where we start. This is where that little baby that we just saw starts. Early in life, we can see fatty streaks develop, and sometimes those can reverse, but they can progress. And so as LDL gets into the artery wall, and I might say as Lp(a) gets into the artery wall as well, what happens is you end up recruiting white blood cells, monocytes come into the plaque, and they find their way into the plaque. They gobble up the LDL, and the LDL and Lp(a), which is another atherogenic lipoprotein, a lipoprotein that can cause plaque, gets consumed by these white blood cells, and they become the typical cell of an atherosclerotic artery. That typical cell is called a foam cell. And as we can see, as you go along the continuum, you may get calcium in that plaque, you get red blood cells, white blood cells that are can be secreting these chemical modifiers called cytokines that can make the surface of the plaque very unstable and ultimately and inflammatory. And ultimately, you may have plaque rupture. The cells of a plaque, cells of a clot, are the platelets and fibrin. And if they are not cleared away, if they continue to grow, you can have what's called a myocardial infarction or heart attack. You can see here that the hallmark of a heart attack is the artery is completely blocked, so no blood is getting through. If that fibrin and platelet clot does not form completely, but you still have a very large plaque, you may have some obstructive disease. And what we see here is that when you try to exercise, or even sometimes when you try to digest your food, this artery cannot expand sufficiently. So people end up getting what's called angina or chest pain associated with the inability to get enough blood flow to the tissues that need it. So over the years, we have learned that LDL cholesterol needs to be very low. And I can remember back in practice in 1994, when the Scandinavian simvastatin survival study was published. That was a landmark study. Previous studies had shown that when you lowered cholesterol, you could reduce cardiovascular events. But this was the first study that showed not only do you reduce cardiovascular events, but you reduce cardiac mortality and all-cause mortality, total mortality. So it was really profound. But the starting LDL in the all-male participants of the Scandinavian simvastatin survival study, the starting LDL was somewhere around 190, 200, managed to get down to around 125. And people started saying, well, it's good enough to get to 130. So we're not waffling, we're not changing our mind, we're getting new and additional information. So that what did we get? We got the CARE trial, the heart protection trial, and the lipid trial. And these showed with more aggressive LDL reduction, or even starting at lower LDL levels and bringing the LDL down further, you still continue to get benefit below 100. And so 100 became the target. And then Prove It compared one statin to another And TNT compared high versus low dose atorvastatin. And these showed lower was even better. And then finally, Improve It came around. And Improve It was a study looking at simvastatin plus ezetimibe versus simvastatin alone in people with cardiovascular disease, and found even getting down around 60, 66, you could get further benefit in terms of cardiovascular risk reduction. And then skip forward to 2018, when the cardiovascular outcome trials of FOURIER and the Odyssey trial. FOURIER studying evolocumab, which is a PCSK9 inhibitor, and Odyssey looking at alirocumab, which is also a PCSK9 inhibitor. And in these studies, where these people all had cardiac disease, they were all on a background of statins, and some were on ezetimibe, and the average LDL starting out was around 90. And these individuals, with the addition of the PCSK9 inhibitor, could get down into the mid-20s. And I will importantly say that the mid-20s, it's perfectly healthy. It's perfectly acceptable. Lower is better. Lowest is best. And so getting the LDL down as low as humanly possible, as we have had studies from 1994, almost 30 years ago, to 2018, we're learning more and more that lower is better. And so what are the goals for adults and pediatric patients, people with and without atherosclerotic vascular disease? And again, atherosclerotic vascular disease is disease in the arteries, whether it be in the neck arteries to your brain, in your heart arteries, or your extremities. And so the LDL goal for somebody without atherosclerotic vascular disease is less than 100. But that doesn't mean that lower isn't even better. Lower is always better. And there's really no downside to getting the LDL down to very low levels. And I would say that this is in contrast to things like blood pressure lowering medicines or diabetes care. You can't, bring someone's blood sugar down to 20, they'll die. You can't bring someone's blood pressure down to 30, they'll die. But you can bring somebody's LDL down to 20 or 30. And there are, as I'll show you, people that are born genetically with very low LDLs, and they do just fine. So lower is better, always lower is better, and it's always safer to be lower. The LDL goal for someone with atherosclerotic vascular disease, an adult, would be less than 70. And again, lower is even better. For a child without atherosclerotic vascular disease, less than 130, ideally even lower. And some children, particularly those with homozygous familial hypercholesterolemia, can get into trouble with cardiovascular disease in the first couple of decades of life. And for those children, we want their LDL less than 70. But just last week, so this is hot off the press, the American College of Cardiology expert panel on guidelines it has said lower is even better. And this is where the American College of Cardiology is coming to agree with the European Atherosclerosis Society, which has said since 2019 that in people with atherosclerotic vascular disease, aim for an LDL of less than 55. So the lower, the better. And why is achieving your LDL goal so important, or that safe zone for your LDL? Well, we know based on data from 170,000 individuals who participated in 26 statin studies, each typically lasting around 5 years. So think about it, in a 5-year horizon, for every 40 milligrams per deciliter you lower your LDL, you reduce your risk by 20%. The same formula appears to hold true for other classes of medications, including ezetimibe and the PCSK9 inhibitors. The bempedoic acid is an agent that's currently in cardiovascular outcome trials, and we'll be able to see if the same holds true for that as well. So I want to talk a little bit about a study that helps us understand how we know that lower is better And how do we know that it's safe to have a really low LDL? And so I would say the bottom line is the longer the LDL remains at goal or in a very safe zone, the greater the benefit. And so this was a study that was published in the New England Journal back in 2006. And it looked at individuals who were born with genetic changes in their PCSK9 gene. So remember, PCSK9 inhibitors block PCSK9 and they lead to a reduction in LDL. But there's some people who are born with what's called sequence variation, so a change in their DNA for PCSK9 that leads to them being born with a very low LDL, and they are protected against cardiovascular disease. And so this is some of the data from that study. And so I'm going to walk you through the bottom line over here. So people who have changes in their PCSK9 gene, it was found that there is a pattern within African Americans where they get a 28% reduction in LDL. They're born with a 28% lower LDL than you or I. And there's a Caucasian or white variation where people are born with a mutation that leads to a lifelong reduction in LDL of about 15%. So these reductions are not as big as the reductions you get when you go on a PCSK9 inhibitor. You start taking it, your LDL may go down 50, 60%. But we're now talking about a lifelong level. You're born with your genes. And so this 28% reduction, lifelong reduction, translated into an 88% reduction in cardiovascular events compared to the rest of the population. And that 15% reduction translated into a almost 50% reduction. And the point here is that it's a lifelong reduction. So that brings us to talking about LDL management in adults with atherosclerotic vascular disease. We're going to talk briefly about the FOURIER trial and then the FOURIER open label extension. So the FOURIER trial, this original study, I'm starting in the middle here, the original FOURIER trial was a trial looking at people with atherosclerotic vascular disease and randomizing them. So these people all were on background statin therapy, and some of them were on ezetimibe as well. They started out with an average LDL of about 90, and half of them got put on evolocumab, which you would know as Repatha, and half of them got placed on placebo. This study included 27,000 people, and the goal was to get it done quickly so that you could see a difference between these two groups. And that is exactly what happened. In the maximum amount of time somebody was in the study was 3.4 years, and many people were in the study for like 2.5 years or so. It showed a reduction in cardiovascular events in favor of those people with the evolocumab added in of about 15%. But one thing it didn't show, it showed a reduction in heart attacks, a reduction in cardiac events, but didn't show a reduction in cardiac mortality. And one of the reasons for that, it was done quickly. And so to the credit of the investigators, they said, okay, we're going to do an open label extension. And when you do an open label extension, you invite people from the original trial, people that were on the evolocumab to begin with, and people who were on placebo during the original trial, or what we call the parent study. And you invite them into an open label extension where everybody gets the evolocumab. And so this open label extension included 6,635 patients. So they chose to do it at some of the sites. So the original study had 27,000 people. They chose certain sites, but these people all looked very much like the people that were in the original study. And so there were 6,635 people who had been in the original study. Of them, 3,355 had gotten evolocumab or Repatha during the original study, and 3,280 had received placebo. So in the FOURIER open label extension, everybody was treated with evolocumab for approximately 5 years. And very quickly, the two groups had similar LDL levels. And in fact, 80% of the study participants were able to get their LDL below 55 milligrams per deciliter. So achieve the new target that the American College of Cardiology is talking about. So I'd like to just pause here and have you think to yourself, who do you think is going to do better during the open label extension? Do you think the people who have already been on the evolocumab for 2.5, 3.4 years, and then they go on for another 5 years, or the people who were on placebo and then get 5 years of evolocumab? And so one very important finding was that the group who received the evolocumab, both in the parent trial and in the open label extension, so some people for as long as 8.4 years, they experienced significantly fewer vascular events than those who only received evolocumab in the open label extension. So compared to the patients who were on placebo in the parent study, those who were on evolocumab for both the parent and the open label extension, they actually enjoyed a 15% lower risk of cardiovascular death, heart attack, stroke, hospitalization for unstable angina, or coronary revascularization than the people who were on placebo originally and then got the evolocumab. So that's called a composite endpoint. You're looking at heart attack, stroke, hospitalization. But those people also got a 20% lower risk of cardiovascular death, heart attack, or stroke. So those are the more hard endpoints. And then finally, you can't, when we say a hard endpoint, you can't dispute it. Somebody is dead or they're not. And they got a 23% lower risk of cardiovascular death. That doesn't mean that the people who only got the evolocumab during the open label extension didn't benefit from it, but it's that longer time that somebody has a lower LDL. It's allowing the atherosclerotic process, the plaques themselves to be changed. So what's the take-home message from this important study for people with cardiovascular disease and high LDL, especially those living with familial hypercholesterolemia who have had elevated LDL since birth? So it's simple. Get your LDL as low as possible, as soon as possible, and really importantly, keep it there. You don't benefit if you get to goal and then you stop taking your medicine. So what do we tell people who have very high LDL? Start therapy early in life. And we have data that individuals who get started early in life, people who have genetic cholesterol abnormalities, they can basically change their course and change their family's family history. If you can get your LDL down early in life, that is really important. Achieve your LDL goal or safe zone. And it's important to recognize that this may require multiple medications. And I often, when I see patients who I know have a genetic cholesterol abnormality or have very high LDL, I set the stage early when I'm seeing them so that they don't feel like they've disappointed me or that they're not getting where they need to be. Some people who have very elevated LDL levels will require multiple medications. We know from our data from our Family Heart Foundation Cascade FH registry that some people require 4 or 5 medications, but often at least 3, just like with Brandon. He was on high-dose statin, ezetimibe, and now he's on a PCSK9 inhibitor. And with those 3 drugs, a man who had an LDL, above 300 is now at 30. Maintaining your LDL goal or safe zone will allow the greatest benefit. The longer you stay where you need to be, the greater your benefit will be. And achieving and maintaining your LDL can dramatically reduce your risk of heart attack and stroke. So the next question is, well, how do you get there? I've talked about statins a little bit. I've said a word or two about ezetimibe. We've talked about a study that included a PCSK9 inhibitor. And so when I look back at the past and I look at where we are now, we are in such a better place in terms of what is available. We know that back in 1973, bile acid sequestrants, they're great, but back then they were just, now they're pill form, but they were just powdered. They were a powdered form of cholesterol lowering resin that you had to mix in water or juice and it takes several times a day, and it was a challenge. Really, a revolution came in 1987 when the first statin, Mevacor, came on the market. It really revolutionized the way we're able to treat people. Lipoprotein apheresis is a therapy that physically removes LDL from the bloodstream. In October of 2002, ezetimibe came on the market, and this drug, when added to a statin, can add another 25% reduction in LDL. Lomidopide is an oral agent that doesn't require LDL receptor activity to work. And this is only available for people with homozygous familial hypercholesterolemia, people who have really dramatically elevated LDL and have inherited 2 genes for familial hypercholesterolemia. Lomidopide can lower LDL as much as 50%. Alirocumab and evolocumab, these came on the market in 2015. And when they are added to statins plus ezetimibe, you can see an additional 50 or more % reduction. Bempedoic acid came on the market in February of 2020. This is a non-statin oral agent. So I should say these alirocumab and evolocumab are injectable medicines. Bempedoic acid is an oral agent, and it can be combined with ezetimibe or it can be added to statins. And you can see an additional 17 to 25% reduction. Evonuncumab has been a welcome addition for people with homozygous familial hypercholesterolemia when added to statins, ezetimibe, the PCSK9 inhibitors right here. This can lower LDL an additional 49%. And finally, inclisiran came on the market in December of 2021, and inclisiran is a PCSK9 inhibitor. But unlike alirocumab and evolocumab, which work in the bloodstream, inclisiran works in the cell, and it inhibits the production of the PCSK9 protein. So these are, although they're in the same class of drugs, they work differently. And so let's talk about the approach. I would say that for most people with very elevated LDL cholesterol, and for most people with genetic cholesterol abnormalities, and for most people with cardiovascular disease, diet and exercise is simply not enough. And what we find is people linger on diet and exercise for a long time. There's a common, a patient might say, please, healthcare provider, give me another 6 months. And the healthcare provider is exhausted and says, all right, you get another 6 months. But diet and exercise can really only lower LDL by about 10 or 15%. And for most people, that is not sufficient. It's important, but it's not sufficient. So what is the diet we recommend? Reducing saturated fat to less than 7%, having no more than 25 to 30% of calories from fat, avoiding trans fats. Trans fats raise LDL and lower the protective cholesterol, HDL. Eat a diet that's rich in soluble fiber. I consult dietitians very regularly. They are the experts, and we encourage regular exercise, but you should know that exercise does not significantly lower LDL. Treating other risk factors aggressively, hypertension, diabetes, the metabolic syndrome, losing weight if necessary, quitting smoking. And it's important for people who have elevated LDL to measure their lipoprotein(a). Research from the Family Heart Foundation has found that fewer than 0.3% 3% of Americans have had their LP(a) measured, and 1 in 5 has an elevated lipoprotein(a). This is a strong risk factor for cardiovascular disease, which we can talk more about in the Q&A. But knowing what your level is important. So what can we expect? I've already mentioned diet and exercise can lower the LDL 10 to 15%. Statins, medium intensity, about 35%, up to 55, even 60% reduction. Ezetimibe can lower LDL by 18 to 25%. The same is true for bile acid sequestrants. And the PCSK9 inhibitors, Repatha and Praluent, or evolocumab and alirocumab, 40 to 65%, depending on which study and which population of people you're looking at. The PCSK9 inhibitor inclisiran or Leqvio, depending on what population you're looking at, it looked at 48 to 52% reduction. And I should point out that not only do these differ where they work in terms of inhibiting PCSK9, evolocumab and alirocumab are every 2 weeks. Evolocumab has a preparation that can be taken every 4 weeks as an injection. Inclisiran, you take a baseline injection, an injection at 3 months, and then it's every 6 months in the doctor's office. Bempedoic acid, 17 to 25% reduction, and there is a combination of bempedoic acid plus ezetimibe in a single pill can lower LDL by about 38%. There are some agents that are used particularly with people with homozygous and heterozygous FH, and lipoprotein apheresis is used also in people who already have atherosclerotic vascular disease. Lomidopide, known as Juxtapid, we talked about that. This is an oral agent, lowers LDL by 40 to 50%, depending on the dose. And even evenunkumab, Evkeeza, can lower LDL by about 49%, and this is a once monthly injection. Apheresis can lower LDL and LP(a). This is actually either a weekly or a every other week procedure where you actually physically remove LDL and LP(a) from the bloodstream by using these columns that adsorb, to basically remove because of the physical charge of LDL or LP(a). These columns have something called dextran sulfate, which is negatively charged, and ApoB on either LP(a) or LDL is positively charged. So you basically, it's like a magnet, and so you get rid of it and you wash it out into a waistline, and so you're physically removing lipoproteins from the bloodstream. There are new therapies in development, and I'll just talk briefly about these. These are for lowering LDL. These are currently in clinical trials, and they've not yet been approved by the Food and Drug Administration, but we'll say a word about them. So Merck is developing an oral PCSK9 inhibitors. So the ones I've talked about, evolocumab, alirocumab, and inclisiran, those are all injectable. Merck is gearing up for phase 3 studies. And so far, it looks like this is given as a daily dosing on an empty stomach. There is an oral CETP inhibitor, obestrapib, and the current dosing strategy is 10 milligrams per day. This agent lowers LDL by 50%. It raises HDL by 165%, and it lowers LP(a) by 56%. This CETP inhibitor is currently recruiting patients for a cardiovascular outcome trial. So it's in people with underlying cardiac disease. It's going to be 9,000 patients. Began in February of this year, and hope for completion by 2026. And then finally, some very exciting a very exciting study started in humans this year. This is CRISPR technology, and it is used to actually change the PCSK9 gene. They're sort of erasing a single base pair in the gene, so altering the gene. And so this is like taking a PCSK9 inhibitor, only it may be one and done. You make the change in the gene, and it will lower LDL in persons. In the study is going to be done in familial hypercholesterolemia. The question is, will it lower LDL forever? And this is being studied by Verve Therapeutics, which is in Cambridge. I will say that the longest studies done with this CRISPR technology have been in non-human primates and have lowered LDL for almost 2 years. So there does look like there's long-lasting effect by this genetic change. And so we've had a whirlwind tour of the fact that LDL is the direct cause of atherosclerosis. We've asked what's the optimal LDL, and you may say, what's my safe zone LDL? Lower is better, and lower is very safe. What are the LDL goals? We have seen that time and time again, the lower you get, the greater the reduction in cardiovascular events. And we've talked about, why does getting to goal or that safe zone matter? And why does staying at goal matter even more? It's like, achieving your weight loss goal. If you don't stay there, you don't get all the benefits. So getting your LDL down and working to stay there. And we've talked about the fact that although lifestyle is crucial, it's crucial for many, many things. For most people, it is not, particularly those with already having cardiovascular disease, it's not enough to normalize their cholesterol. And we've talked about lipid-lowering therapies and those on the horizon. And I'm going to end here and move back to Kat.
Hi, Dr. McGowan. That was really amazing. And so much important information. We've had such nice comments about thanking you for sharing this important information in the chat, and we have such great questions also. So I wanted to start with some of those questions, and I think your message is loud and clear. Some of the questions are related to how low is too low. I think you answered that, but we have a great question about interesting, this idea that once you start taking a statin, will you have to start taking a statin for your whole life? And would you consider that a statin dependency? I think that's a really interesting question. How would you address that question? Once you start, can you stop, and are you dependent?
Yep. So no, that's an excellent question, and I get it a lot of times in my practice. And so what I tell people is statins are not like, for example, certain drugs where if you start taking them, you really have to gradually wean off them. An example is a beta blocker. If you stop a beta blocker, which slows the heart rate and is often used in patients with cardiac disease, you feel miserable. The same is true for medications like Zoloft or Prozac. If you start them and then you abruptly stop them, that's horrible. You just feel terrible. But with a statin, statins block an enzyme called the HMG-CoA reductase enzyme. And statins have a short half-life. So when you stop taking a statin, it stops working. So if you stop taking your statin within 2 or 3 weeks, your LDL level will be where it was at baseline. It won't go higher or anything like that, but it will go back to baseline. So you only benefit from the statin while you're taking it. I don't consider it a dependency, but it's very important to know that if you're on a statin and you stop taking it, your cholesterol values will go up. And so sometimes people would want to be on less of a statin. And so for them, we can often use a lower dose of a statin or every other day statin plus ezetimibe and get to the same spot. But statins only work while you're taking them.
And that's the same for the other treatments as well.
That's correct. So ezetimibe also has a short half-life, and so if you stop taking it, your cholesterol goes back up. The PCSK9 inhibitors have a slightly longer half-life. That's why, you're not taking them every day. You're taking them every 2 weeks or once a month at a higher dose. But they too, you stop for a while and your cholesterol will go back up. So these drugs work while you're on them and stop working when you're off.
So I think a related question is, will rapidly decreasing your LDL destabilize plaques? Is there anything about what if you start a medication and your LDL goes down quickly? Is there any downside to that? Should we be gradual in our treatment?
There's no evidence that that would cause a destabilization of plaque. If anything, you would start seeing lipid sort of eke out of the plaque to neutralize things, to keep you can get cholesterol. So if you lower LDL dramatically, you can actually see some decrease in plaque size, and it happens over time. So it's actually a very good thing. There was a question, if you abruptly stopped a statin, could that cause destabilization of a plaque? And this came up during some of the clinical trials, the early clinical trials. We used to take people off all of their cholesterol lowering medicines to see what their underlying lipids were. And there was a concern that abrupt discontinuation of a statin could cause destabilization of plaque. And I actually published a paper on that with the TNT trial, and that is not shown to be. So you abrupt discontinuation or abruptly lowering your LDL, neither is a bad thing.
All right, that's very helpful. And so I think also another interesting question, what do you think about taking more than one statin? I'm not, at the same time, I'm not sure I've heard that that's advised.
Never recommended. And because, think about statins. So you start on, let's just take atorvastatin, for example. The lowest dose of atorvastatin is 10 milligrams. When you double the dose of atorvastatin to 20 milligrams, you lower the LDL 10 milligrams, you lower the LDL about 38%, 20 milligrams about 44%, 40 milligrams about 50%, and then about 56% with the 80 milligram dose. So it's the rule of sixes. Every time you double the dose of a statin, you only get an additional 6% LDL reduction. So with atorvastatin, you go from a 38 to about a 55-56% reduction in LDL. And if you were to add another statin in, you've already, probably maximally diminished the HMG-CoA reductase enzyme. So you're not going to get any further benefit, but you can get harm. You can get an increased risk for side effects. And so this sometimes comes up when people don't realize that red yeast rice is like taking a mini dose of a statin, and they take that because they think it's an over-the-counter medication or an over-the-counter thing that they can take, and they add it to high-dose statins, and that could become problematic. So never take more than one statin.
I wonder sometimes if people, because I think you've explained that there are statins, and then there are these other non-statin treatments, and I wonder sometimes if people might think that they're taking two statins when they're really taking a statin plus ezetimibe or something else.
Right.
I would be surprised if a physician were prescribing more than one statin at a time. So another great question about therapies is, do any of the LDL lowering drugs interfere with other cardiovascular drugs like beta blockers, other high blood pressure medicines, or diabetes?
No. So we're pretty lucky with the, statins, ezetimibe, bempedoic acid, and the PCSK9 inhibitors. Bempedoic acid does have some interaction with statins. So there are some limitations on the dose of statin you can use with bempedoic acid, but otherwise, really no issues.
Great. And the other question that I thought was very helpful, and I'm looking for it again. Oh, what is the role of Vascepa? Since we've talked really about high LDL, but often people have a high total cholesterol, they don't always understand, is their total high because of their LDL or is their total high because of their triglycerides? And that's so important. And what is the role of Vascepa? Or you could say the other name for Vascepa. I don't know how.
Yeah, so Vascepa is uh, I'm blanking for at this moment, but it is an omega-3 fatty acid, and it'll come right back to me, ethyl something. So Vascepa is an omega-3 fatty acid, and it lowers triglycerides, just as fish oil does. And there was a clinical trial that showed that added to statins, particularly in people who have diabetes or modestly elevated triglycerides, Vascepa could reduce the risk of a cardiovascular event by about 25%. And it is a somewhat controversial study, but the facts remain that Vascepa versus placebo reduced cardiovascular events. It's particularly beneficial in people with elevated triglycerides and or diabetes. And so it can be used, and it should be used, but for people with if their main reason for having elevated cholesterol is a high LDL, Vascepa probably doesn't have much of a role. If somebody has what we call familial combined hyperlipidemia, or if somebody has very elevated triglycerides, I would say Vascepa has a role.
Thank you.
Thank you, Mary Card. Icosa pentethyl. So Mary Card and I worked together for 20 years. She's always got my back.
Yes. Okay, terrific. So we have so many good questions. We could go on for a long time, but I think we need to wrap up and address some of these questions in another webinar. We hope you'll all come back and join us. And I thank you, Dr. McGowan. I think we have a few closing slides to share. And I do want to say, maybe you could make one comment, because some of the questions were about side effects. And of course, everybody has to be very responsible and careful and consult their healthcare provider. Could you make a statement about the potential side effects of drugs, and also the recent study about the side effects of statin drugs?
So in which recent study are you referring to, Kat?
The study that showed that it studied that showed that many people who report side effects from statins were on placebo.
Yep.
And so not in any way to diminish the very real side effects that we absolutely know that some people have, but also there are people who won't even start because of what they think is happening. So there's that balance between, of course, all of the treatments that you've mentioned have side effects. Drugs have potential side effects.
Right. So one thing I would say in the field of cholesterol metabolism, there are the side effects of cholesterol lowering drugs are really pretty minimal, but we don't want to just say there are none. And so obviously people know about statins having the potential to cause muscle aches. But as you say, there have been multiple studies that have shown that just as many people in the placebo group have muscle aches as those in the, or it may be slightly more in the statin group, but it's very, very close. And so sometimes what we think is a side effect of a medicine is just because we, overexerted over the weekend, or we tried to lift too many boxes when we were moving. Not to diminish them, but the benefits are so great that unless you're absolutely certain, I wouldn't prematurely stop a medicine. Ezetimibe is incredibly incredibly well tolerated. It's our go-to drug when people have difficulty with statins. And it can have some GI issues occasionally, but most people tolerate it beautifully. The PCSK9 inhibitors, other than sometimes a little injection site reaction, they really are incredibly well tolerated. And I think I saw that somebody asked about what are the restrictions with bempedoic acid. I think you cannot use more than 20 milligrams of simvastatin with bempedoic acid, and there's also a restriction with pravastatin. Luckily, there's not a restriction with the most commonly used statins, atorvastatin and rosuvastatin.
Thank you so much. Well, thank you for another great presentation. I think this is such an important topic, and we know that there are a lot of questions and misperceptions and concerns. We would invite anybody who's attending. We need your support at the Family Heart Foundation. We're a nonprofit research and advocacy organization, and your support helps to bring programs like this to you and available for you to share. We want to invite anybody with questions. A lot of people had questions about testing and where to find a doctor. Please come to our Care Navigation Center. We have a great team standing by to answer your questions and connect you with the right care. So you just go to familyheart.org/care for the Care Navigation Center. Thank you all for joining. Thank you, Dr. McGowan, and thanks to Amgen and our Family Heart partners for helping us to make this possible. We're always here for you. Contact us anytime. Thanks so much.